Okay. Again, thanks for joining us, everyone. Today, we will be hearing from Dr. Richard Cheng, who is an assistant professor of medicine in the Division of Cardiology and Section of Advanced Heart Failure and Transplant Cardiology. He completed his cardiology fellowship training at Cedars-Sinai, where he also completed both interventional cardiology and advanced heart failure training. Dr. Cheng's research focuses on therapeutics of cardiogenic shock, as well as minimally invasive repair of mitral valve and tricuspid valvular disease. He is currently involved in the Accusant ventricular restoration systems trial in patients with heart failure with reduced ejection fraction and mitral valve disease, and has nearly 50 peer-reviewed publications. Really looking forward to your talk, Dr. Cheng. A reminder that if you have any questions, please feel free to put them in the chat, or you can raise your hand and I can have you ask your question in person.
Thank you so much, Joyce, for that nice introduction. So thank you, everybody, for your time and joining the talk. I have the privilege to present this topic, interventional and device-based therapies for the heart failure patient, cardiogenic shock and beyond. And it's really a field I'm very passionate about, and that's been evolving really quickly over the past few years. So I'd like to focus on two parts. So really like to persuade you that it's really part of the same spectrum of patients. In patients with cardiogenic shock, I'd like to persuade you that outcomes can be improved for patients in shock with early recognition of shock with the shock team approach, the standardized, protocolized, uniform, and multidisciplinary approach, with close collaboration with CT surgery, cardio-intensivist, but also AHF and interventional cardiology. And that interventional and device-based therapies can offer exit strategies that we may not have had in the past. And for patients who may not yet be in shock, but with persistent heart failure despite medical therapy, so-called refractory heart failure, if you will, that interventional heart failure as a field can utilize existing interventional therapies, but also novel interventional and structural heart failure trials that are emerging and enrolling as we speak. So I think we've all seen a slide like this about cardiogenic shock, and essentially it is where, for whatever reason, maybe congestion or myocardial infarction or decompensated heart failure, or cardiac output states, a dilated ventricle, you have a low cardiac output. That leads to low blood pressure, vasoconstriction, and worsening cardiac output. This then leads to a spiral where you end up with organ hypoperfusion, resulting in essentially a death spiral with multi-organ dysfunction. We have tried to use temporary MCS, prescribe it in a very routine way over the past decade and a half. IABP Shock 2 is probably the largest balloon pump trial looking at patients with acute myocardial infarction, cardiogenic shock, with PCI or CABG planned, randomized 1-to-1 with balloon pump or no balloon pump. The majority of balloon pumps were placed after PCI, about 80% of them. It was generally not a very sick cohort. CP Impella has been tried as well, IMPRESS, STEMI, cardiogenic shock, immediate PCI, randomized 1-to-1 Impella CP or balloon pump. Again, majority of patients were randomized after PCI when they were still in refractory shock, 80% were post-PCI. And of course, this JAMA analysis that came out a couple of years ago, there were a couple of them that were really thought-provoking. This one in particular, looking at cath PCI and chest pain MI registries, combining the two, looking at patients with PCI for acute myocardial infarction, complicated cardiogenic shock, with Impella matched 1-to-1 to balloon pump. They actually found more vascular injury and vascular and blood transfusions, et cetera, on the Impella arm. Of course, patients with multiple devices, including balloon pump failure, with analysis, maybe making the balloon pump a rosier result. But the summary of these trials is that they are all negative trials. And we can't routinely use temporary MCS and prescribe them in routine fashion for cardiogenic shock. And so again, early attempts to routinely prescribe TMCS for AMI cardiogenic shock not associated with benefit. I think this is where the field sort of starts. But the field has moved on in two major ways. First of all, we are increasingly using temporary MCS for decompensated heart failure, cardiogenic shock, which is a different etiology of cardiogenic shock, of course. And there's a lot of different reasons for this. There's also a movement towards a multidisciplinary approach to not just look at devices in a vacuum in the cath lab, but also involve advanced heart failure and CT surgery to consider bridge options. And so we can prescribe devices in a nuanced fashion, knowing where we're trying to go. and not what we're seeing right in front of us. And there is some data for this approach. This is now pretty old data, but US PELA is a registry of patients with Impella. This was mostly 2.5, so the prior generation Impella. They were looking at patients with Impella placed pre or post PCI for acute myocardial infarction cardiogenic shock. And what they found was that patients had PCI first and then Impella post, while whether or not they had balloon pump pre, their survival was about 40%. But for the patients where you were aggressive with support early on to perhaps halt or treat the cardiogenic shock cascade before proceeding PCI, survival seemed to be higher. Of course, this is registry and non-randomized, non-prospective data. And in balloon pumps, a therapy that historically we've used for increasing cardiac output, especially for patients who are ischemics and perhaps a little bit older, that was the classic teaching, has somewhat been turned on its head with some recent data now 4 years old. This is out of Colombia, 132 patients with chronic heart failure, really a population of patients that the AHF patients were a group was seen there who had a baseline cardiac index of 1.6. These patients all got balloon pumps and asked a few good questions. One, what happened to cardiac output after putting in the balloon pump? And you can see that every one of these bars is a different patient. And you can see that there are some patients that actually had a decrease in cardiac output, some patients that had a modest increase. Now, obviously, if you looked at just this half of the graph, you would say balloon pumps don't really work. But there were patients that were these super responders that had an improvement in cardiac output that could be sometimes quite dramatic. So then they did two multivariate analyses. One, they looked at patients with an inadequate response to balloon pump therapy. And what that they mean about inadequate response is that they had poor outcomes, essentially. And then they also looked at patients who had a robust hemodynamic response to balloon pump therapy, whether or not they had a good or bad outcome. Where was it? Which patients did the therapy actually improve cardiac output? So first, patients with ischemic cardiomyopathy actually did worse with balloon pump therapy. Associated with worse outcomes in patients that got balloon pump therapy and patients that had RV failure. So as evidenced by a PA pulsatility index of less than 2, they didn't do well with balloon pump therapy. Patients that did well hemodynamically to balloon pump therapy were older. That makes sense. Surprisingly, patients that were non-ischemics, and again, kind of back to the PA pulsatility, patients with high PA pressure. So I use this to, when a patient comes that may be in classic shock, but not deteriorating too quickly, who might be a non-ischemic with acute decompensated heart failure with high SVR, with high PA pressures and normal RA, that's a patient that could potentially still benefit from balloon pumps. So I'm not sure balloon pump is dead for cardiogenic shock just yet. This is a different cohort patients, balloon pump for AMI versus acute decompensated heart failure. We split these two cohorts out and reported them separately, 71, the AMI cohort, 132, the decompensated heart failure cohort. And what interesting graphs. In the AMI cardiogenic shock cohort, the patients we may think that balloon pumps to help coronary perfusion, there really was null in improvement in cardiac output across the cohort. But it was the patient with acute decompensated heart failure that really had this tail of super responders with balloon pump. And really, when they looked into the weeds, they found that cardiogenic shock patients had a 5-fold greater cardiac output augmentation, but that it was mainly driven by reducing SVR. Perhaps patients that had borderline blood pressure where you're not comfortable starting iPride, a balloon pump could potentially be very helpful in these patients. So again, the idea that we should prescribe devices as opposed to use them routinely for patients with shock. There's also evidence that certain devices may work better for other devices depending on the etiology of insult and cardiogenic shock. This is a swine model that got a lot of attention where they looked at patients, swine, including their LED for 120 minutes, the last 30 minutes of which a few of the swine, I think there were 10 total, 4 got no pump. Some got transvalvular pump, so like an Impella-like device, and some got a VA ECMO. And what they found was that for the swine that got a transvalvular pump, like an Impella sort of device, the infarct size, this is the gray here, the infarct size was smaller than those that got no pump or those that got ECMO. The swine that got ECMO had the largest infarct size, perhaps due to increased afterload and increased work for the LV. So suggestions that different devices have different even mitochondrial and infarct size profiles. Here, look at the mitochondrial function, similar story. Those that got a transvenous pump at the end of the experiment have very similar mitochondrial function as non-infarct area. So infarct in orange and non-infarct in blue, whereas those that had not get a pump or ECMO had decreases in C1, same as that in the swine that got ECMO. So there's definitely a tension between randomized data, gain randomized data, mostly in acute myocardial infarction, definitely very routine use, a lot post-PCI when the cardiogenic shock has progressed, and meta-analyses and registries, and then real-world experience in translational science, I think, in this field. And I think the reason is because we're talking about a very heterogeneous population of patients, a 55-year-old with acute myocardial infarction, cardiogenic shock, post-PCI, and catecholamines, or one pre-PCI without adequate blood pressure, or a patient with dilated cardiomyopathy, sliding slowly inotropes, even the same patient, but on a transplant list, who has the option to get a transplant and have an exit strategy. That's different from a 55-year-old with VTVF arrest, no ROS ×3 shocks, ongoing ACL, SDR. And they add to that, biological differences, and some are following myocarditis. And of course, now we're seeing a lot of MISA in patients who are unvaccinated COVID. That's even different than pulmonary myocarditis when it comes to the trajectory and treatment course with anakinra and salmeterol, patients with post-cardiotomy shock, post-transplant with primary graft dysfunction, even post-transplant rejection, all very different because the destination might be different, and therefore the treatment course may be different, and the support devices may be different. And this paper on this topic, published a couple of years ago, really kind of delved even further into other etiologies. And of course, again, in trials, we try to summarize it as AMI cardiogenic shock or ADHF cardiogenic shock, but really it's much more heterogeneous even than that. There's been attempts to try to use a language that can help different specialties communicate with regards to cardiogenic shock. I think earlier on, we used NYHA or KILT class or ACC-AHA stage as a surrogate. I think Intermax, which is a profile staging criteria for patients that are going for bad. So Intermax registry, ventricular assist device that is, was probably the first I saw that injected trajectory, right? So that patients, the trajectory of the patient mattered in the stages, not just, well, their lactate is 5, therefore they're stage 1, or their lactate is 10, well, what's the trajectory? How quickly are they decompensating? So Intermax 1 being the worst, crashing and burning is the official shorthand. Intermax 2, sliding fast inotropes. Intermax 3, stable, continuous inotrope dependent, et cetera. Really this is more helpful for patients with acute on chronic ischemic or non-ischemic dilated cardiomyopathy going for bad. But I think the idea of velocity became front and center, at least in the AHF groups around the country when this came out. And then now more recently, I think a couple of years ago, 2-3 years ago, SCI, an Interventional Society with ACC, with AHA, with STS, with SCCM, came up with A-to-E stage, SCI shock stage. And what is unique about this, again, it does add the velocity, but it also adds 3 pillars, right? The biochemical markers, looking at lactate, looking at bicarbonate, looking at urine output, and then hemodynamics, again, kind of coming front and center in cardiogenic shock. So somebody who's classic shock would be somebody who might look like they're into class 3 or 4 AMI, their lactate may be greater than 2, their urine output is low, their BNP is elevated, and their cardiac index is 2.2, and their cardiac power output is less than 0.6, but that's classic cardiogenic shock. Deteriorating cardiogenic shock, that velocity, they're worsening, they're using the support devices, but they're still worsening on that, their lactate is still elevated, and extremis, of course, patients that are essentially coding in front of you that you're thinking of putting on ECMO or whatnot. And does this does this grading system matter? Does it prognosticate? Well, Mayo took a look at a 10-year experience of their CICU, and they must have used machine learning, but they graded their patients at stage A, B, C, D, E, and this is based on their initial presentation to the CCU, and they found that patients in extremis shock, of course, had worsened adjusted odds ratio for hospital mortality than D, then C, then B, then A. So it seems to be associated with survival. And if you look here, of course, patients that were in stage E extremis shock, but also had cardiac arrest early on in their mission, while they clearly had worse mortality than those in the blue bar that didn't have cardiac arrest. And then you could look at the left chart here, where ACS or heart failure or neither, of no matter what the etiology, the degree of shock and initial presentation mattered to survival. I do want you to try to remember that generally in their cohort, stage D had 60% survival, and stage E had 33% survival. We'll show some of our data from our center as well. And this is all in the context of more and more places developing these pathways and these protocols, and I'm not going to go into them in detail, but essentially there are pathways and protocols for patients who come into the cath lab with STEMIs or NSTEMIs with cardiogenic shock. That's the National Cardiogenic Shock Initiative algorithm. So not to capture heart failure, this is all ACS, cardiogenic shock and AMI. And then there are places that have adopted that mostly for MI, like Wellstar, for example. And there are other places that have taken a more nuanced approach that look at both AMI and ADHF, cardiogenic shock. And again, just showing obviously non-randomized, obviously lots of co-founders, but the idea that once you initiate some sort of shock team cohort, shock team or multidisciplinary approach, that survival seems to be improved as compared to prior. And probably the best known group that has really advocated for this shock team approach is Sonova, where they have a very robust and complete algorithm for both AMI and acute times heart failure, cardiogenic shock, and showing that with implementation of this algorithm, that from year to year to year, survival seems to improve in the cohorts. What I found was really neat about what they had here was that if you look at risk factors for poor survival or poor outcomes, well, if you put in a support device, so or the shock team has been activated and they've seen a patient, 24 hours later, their lactate is still greater than 3. Well, of course, that's going to be associated with really poor outcomes. But the idea that at initial activation, if the patient had already been on pressors for greater than 36 hours, those patients had the same predictive value for poor outcomes as having a lactate that's persistently elevated. I thought that was really profound, because I do see a lot of that type of practice of putting inotropes on, maybe putting in some vaso and seeing how they do and trying to digrese them. We do that a lot, and that does seem to be associated with poor outcomes. And what they identified was that in their healthcare system, I think many of us could see this in our practice as well. For cardiogenic shock, there is fractured care, there's late detection, there's impaired access to care, and there's variations to care. And we need to work on that. And no matter what shock pathway you see, at the end of the day, there's two major similarities. There's always a multidisciplinary shock team with a quarterback that is versed with shock and understands all the treatment options. And there is a right heart cath, clarifying patients based on their hemodynamics to have biventricular shock or LV dominant shock or RV dominant shock. And of course, thinking about the different options and circuits that we have for each of these etiologies. And there was this neat paper that came out a couple of years ago, I believe in JACC, that looked at PA catheters. Of course, we know from prior experience, routine use of PA catheters in patients not in cardiogenic shock, but just for acute times heart failure does not help. And so that's obviously fallen out of favor. But actually, there's not a lot of data on PA catheter use in patients with cardiogenic shock, a cohort that was most excluded from prior randomized experience. This is a thought-provoking paper, a single center looking at the use of PA catheters. So patients that had no PA catheter use that were in cardiogenic shock, for patients who had a PA catheter, but there was incomplete documentation of all 4 hemodynamics. That's the ones in the orange. And patients that had a PA catheter where all 4 plus RA pressure was routinely recorded, routinely used. You could see that patients that had complete assessment had a lower mortality in each SCAI stage, CDE, than compared to incomplete assessment compared to no PA catheter use. Obviously, again, retrospective, but really interesting data. And this is a really exciting time. I think the field has always been criticized for not having randomized data that supports the use of any devices in patients with cardiogenic shock. And the argument against that approach is that these patients may be dead without the devices we're using. And this is a trial that was published a couple of years ago called ARREST, single center RCT in Minnesota, ECPR versus standard ACLS. They're looking at survival with favorable neurological outcome. The sample size had initially been 180, but they were analyzing data every 30 patients and deciding whether or not to continue the study for futility or for ethical reasons. The estimal transport time was less than 30 minutes. These are patients with adult VF, pulses VT, no return of spontaneous circulation after 3 shocks. Very importantly, this is a community that is well educated. 83% of these patients have bystander CPR. That's really, really high. On average, these patients have 5 shocks, and none of them arrived in the ED with return of spontaneous circulation. They were randomized at that point to 2 options, ECMO or control. Patients who went randomized ECMO were immediately taken to cath lab, and they were placed on via ECMO in the cath lab. And from the time call to via ECMO initiation, 59 minutes, also very impressive. Control arm had ongoing ACLS, usually for another 30 minutes on average. And then if they had ROS, they would go for angiography. The time of CPR duration from call to death, 81 minutes, they did try for some period of time to get these patients back. I would also add that for the ECMO arm, I think only 1 patient got PCI. So it's not because they got to the cath lab, they got PCI that they did better necessarily. And here are the outcomes. Survival to hospital discharge was greater statistically in the ECMO group, 6 out of 14 patients versus 1 out of 15. And 6-month survival was actually 6 in the ECMO group. And this was with favorable neurological outcomes, and no one in the ACLS group survived. For that reason, they ended the study after 30 patients. Of course, patients that did survive ECMO had a long, arduous course. The median length of stay was 26 days in that arm. Clearly, this is a single center study, has not been replicated. It's a center that has a lot of practice with ECPR, ECMO CPR. There were really high rates of bystander CPR. 83% is not something we routinely see in California, and the numbers are small. But does lend credence to the idea that if we don't do something, often these patients end up succumbing to their cardiogenic shock. We have created our own shock pathway that has actually gone through multiple iterations, but generally speaking, the idea is to standardize standardize the activation and get all the right people involved. And generally now it's going through our CCU attending, who also has a CCU 24/7 number. We do have an initial assessment that is that can be used. It's a note that's shared with all the fellows and the CCU attendings, where the usual considerations we think about in cardiogenic shock, things we're looking for in bedside echo, like LVEF or LV dimensions, visual motion abnormalities to look for, perhaps AMI, evidence of LV thrombus that may modify our choice of support device. RV function, same concept, looking for perhaps a PE as a reason for shock with RV apical wall hypercontractility, etc. Doing cardiac power assessments available. A lot of this can be done using the right cap numbers, or sometimes just by echo, VTI, and then looking at things like lactate, etc. And having and then using a language like SCAI shock stage or intermax profile to give a sense of urgency for these patients. In the cath lab, we encourage our operators to think about this this flow diagram. They should start by taking the patient and asking just how sick are they? Are they sliding or are they crashing, burning? Patients who are crashing, burning probably shouldn't have a right heart cath first and numbers and a balloon pump. The patients who are beginning or sliding on either stroke probably should have right heart cath first, as opposed to jumping straight to an Impella device or ECMO. And then as they flow down these flow sheets, for patients who are not as sick, you can potentially do a balloon pump and reassess their cardiac output goes up a lot, or if they don't, just take it out and put in a CP Impella in the same access site. And then for patients with PVAD, using a right heart cath to determine whether or not they are still in refractory shock and therefore need ECMO or RV support based on their PAPI or RA to wedge ratio. And patients with ECMO, asking the question about whether or not they need a vent. That is things such as a lack of posterior ECMO, refractory hypoxemia, arrhythmias due to elevated LVDP, or even for some patients, giant cell myocarditis can be potentially benefited from LV vent. So just really thinking about all the things that we usually think about in patients that need support devices. And so looking at these pathways we've started about a year and a half ago, how are we doing? So, we're up to 60, 70 activations now, but just last time I looked at the data, December 2020 to October 2021, 47 shock activations, 3 that we captured, some were not captured. We don't have a perfect way of capturing it, but 3 excluded due to pure non-cardiac shock reasons. They were not good activations. Over the 44 patient mean age activation was 55, 84% were male, 57% were transfers, and 30% were QMI. You could see that the blood pressure was generally borderline, and the median VIS score is 23. So that's like 23 of dopamine or 23 of dobutamine, or obviously things added together. And median lactate was 5 at the time of activation. Median LVEF was 22%. This excluded patients with RV only shock, so RV failure shock. And LVOT-BTI was 10 in these patients. And they're really sick. We got very few beginning shock patients. Our majority of patients were evenly divided between classic, deteriorating, and extremis shock, and classic shock patients with elevated lactate. 45% had a cardiac arrest. That's documented in the chart perhaps more. 25% required a balloon pump already. 25% required a balloon pump from this cohort. 21% required an Impella, and 50% of our patients required ECMO. So very, very sick cohort of patients. But even with that, 69% survival to 30 days and 61% survival to hospital discharge. And if you look at that, of course, sky stage had a lot to do with whether or not they did well. So the initial sky stage was B, 100% survival, C, 75, D, 75, E, 33. And this correlated with obviously different VIS scores and more cardiac arrest in the sicker cohort and higher lactate. And if you look at Mayo, which is a large experience looking at a similar cohort of patients, focus on, for example, sky stage D patients, deteriorating shock patients, somebody you really need to act on immediately with the right support device. The way we had graded our patients, these patients on average had a VIS score. Again, this is like 32 of dopamine, for example, of 32, whereas Mayo stage D, their patients was about 5. Our lactate was about 5.3, theirs was about 3.6. CPR, theirs was slightly higher. We had a much larger predominance of ECMO in the sky stage D patients because they were deteriorating. And our survival here was 75%, whereas theirs was 60. So I think we're doing pretty well. And some, what I thought were patients that were not going to make it, but just kind of as a, two obviously anecdotal examples of patients that perhaps without a really rapid response may not have made it, I wanted to share with you. One is a 37-year-old male who presented at St. Francis Hospital. He speaks 4 languages during the pandemic, but he was out of a marketing job. He had 15-year history of heavy drinking ongoing. There was a report that he might be homeless. That was what the referrer had said to me. He had presented there with shortness of breath, malaise, possible alcohol withdrawal, and had AFib RVR. He was hammered with diltiazem and metoprolol and amiodarone. And then later they found on echo, and this is the echo they sent me, that his EF was 10%, looked dilated, and you could see this gelatinous LV thrombus and LV that was barely moving. releasing to, because of worsening respiratory distress, was intubated and coded during intubation. He had a PA arrest. He had 12 to 14 minutes until he had returned to spontaneous circulation. One really important question we always ask is, how do they look neurologically afterwards? Well, it was said that he was reportedly moving afterwards, but he's intubated. They're not quite sure. And this was when they were putting in lines to seem agitated. It was cooled, and he's on Levophed 0.4, very high dose. Epi 0.3 is VIS 70, again, very high dose. He's on renal failure. His IOTs were in the 2000s. His T-bill was 4, his lactate was 13, his pH was 7.16. He was on high doses of Levophed, Epi, and Basal, etc. And the question, of course, was, well, somebody who is an active drinker probably doesn't have a lot of bridge options. And I was very hesitant to take this patient over. But talking to my CT surgery colleague, we decided to get him cannulated at St. Francis onto ECMO and brought over. And despite the lactate of 13, we usually have thought to be too prohibitive for rescuing. And he actually did okay. So he had a long course. He actually needed cardiac tracheostomy. He was a big guy. Had respiratory failure from weakness, but that was eventually decannulated. And thankfully, a lot of his EF being low was not necessarily due to alcohol, but due to the diltiazem and the torpor and the amiodarone that he was getting. And his most recent EF now is actually 54%. Remember, he had renal failure, was on dialysis. Well, that resolved and that was removed. He had a lovely family from Ohio that flew in when he came to us, and he returned to Ohio with his family. Another case that similarly, a very sick patient, a 60-year-old male with diabetes, who presented to SFGH with RCA STEMI, his first PCI, and he had a PCI for troponins 41, and peak troponins 800. And overnight, he had residual disease that included left main, LAD, osteosurf, right to left platos. It was very difficult to tell from angiography, and because he was on high dose pressure this time, where the lesions are and how much that was vasoconstriction. But overnight, he developed cardiogenic shock. There was concern that might be decayed due to high glucoses, but he had worsening acidemia on it. In the morning, we heard about the patient, and we had, they were getting him on CRT, but even with that, he had worsening pressure requirements. He had complete heart block. He was getting transvenous paste. He was told to us that he was a current smoker, possibly illicit substances. At the time of request, doping was at 20, Levophed was at 0.36, Epi at 0.36, Basal was 0.04, lactate was 18, the IS score is probably over 100. He already has a balloon pump, his UF's 10%. And in fact, his transvenous pacer had no longer stopped. He was no longer capturing. He was actually being transcutaneously paced because he was too acidemic. And so same kind of thing where I really didn't feel like he had good exit strategy and exit options. But talking to our colleagues at Zuckerberg, we really felt strongly that we should give this guy a chance. Really, the most rational thing was to get him cannulated in the ECMO. He actually did well physiologically on ECMO. And in fact, his dopamine epinephrine was weaned off completely. This is his angiogram after the PCI. Oh, sorry, this is not cropped right. And this is his initial TTE that shows the air valve wasn't opening. So again, this is why it's really important that we receive these patients and know how to react to some of this physiology. His ECMO flow was high, he was doing great, but his inotropes had been weaned off. And his LV, being very weak, was not able to open to afterload the ECMO circuit. And so probably was developing north-south syndrome. You start inotropes, didn't do very well that night. He had profuse GI bleeding, disturbing ischemic bowel, ASD-ALT with a 4,000, 9,000, LIP was 972. We're gonna do an impella to vent the LV, but decided against it because the aortic valve was opening with inotropes and because of all the bleeding issues. He was on CRT. He had a balloon pump, which we took out at bedside. But we gave him time. He didn't really have a lot of exit strategies, but after a long, arduous hospital course, he did survive. And his most recent ES, 45 to 50%, is off HD. And Jonathan at Zuckerberg has him on quad GDMT. For patients that don't recover immediately off ECMO, we have other bridge options. The reason we couldn't use it on those two patients was because there was no clear durable exit strategies with VAD or transplant because of their alcohol use and substance use, respectively. This is a paper on a single center of 64 patients severe cardiogenic shock that were bridged with Impella to decision durable valve heart transplant, really used by AHF there in CT surgery that were part of the AHF group. And in those patients, 70% survived, 69% survived to next therapy, some of them directly to OHT. In fact, the 16 patients that were directly bridged with Impella to OHT, all live at long-term follow-up. And this is something that we're using, this sort of device is something that we're using for this specific reason more and more here as well. This is another cohort that came out around the same time, Shelley Hall's group, 3 centers in Texas. They looked at just the 5.0 Impellas, 7.7 Impellas in 58 patients. They also saw very similar survival. They also bridged a large minority of them straight to transplant off Impella. This is a patient that we know well in the HF group here. That was here a few months ago with the 5 Impella in his left axillary artery, if I remember correctly. It's sitting in the chair doing some exercises, waiting for transplant, and he eventually got a heart kidney transplant. There are other options too. We could do percutaneous axillary access enclosure for balloon pumps or Impellas, but generally balloon pumps. This has been described both surgically and percutaneously as early as the early 2000s to 2010s. And even back then, they were using this to bridge patients with transplant. This really picked up after the 2018 UNOS criteria was updated to prioritize patients with balloon pumps. Generally, you would be a little more aggressive with the use of balloon pumps in patients' cardiac shock because of that reason. And here we've done 15 patients, 18 devices. Initially, 5 out of 15 were on femoral balloon pump, 2 out of 15 were on ECMO. Mean duration on balloon pump could be 9 days, but upwards of 44 days. And survival to next therapy was 14 out of 14. One of them wasn't a bridge to transplant or bridge to bad patient. And overall long-term survival is 86%, 92% for BTT. So no stroke. So you could do it if you're very careful with a very clear protocol for these patients. You know, they could have it upwards of 44 days and use it as a way to get to next therapy. This is one of the more recent patients showing our access point. This allows them to ambulate, of course, in the second to third segment of the axillary artery. And if you look at interventional heart failure in supporting patients to transplant, again, with the 2018 changes to our listing criteria for interventional to actually putting in devices or whatnot, excluding patients with ventricular device, 2/3 of patients are requiring an Impella balloon pump to move forward. So quite a large number of patients are, if you add that to that, well, that's really, you know, patients are really need VAD or temporary MCS, the both to move forward. Probably 75% of patients now get to heart transplant in that fashion. And so there's more and more collaboration, if you will, between interventional cardiology and heart failure. And there has been questions about whether or not that could be the same specialist. From the heart failure side, this is a heart failure specialist, Dr. Cassie, asked the question, well, should we have an invasive heart failure specialist? And these are doctors that have diagnostic coronary angiography skills, do right and left heart catheterizations, may do IVUS, especially for post-transplant patients for CAV, transplant vasculopathy, or transplant coronary artery disease. They may put in percutaneous MCS, for example, Shelley's Hall's group, the heart failure specialists, the heart failure docs there put in the Impellas with vascular surgeons in the axillary position. They would obviously do biopsies and they would do PA pressure sensors. Even beyond that, even in the interventional space, there is the question whether or not there is the role for interventional heart failure specialist. This is a paper out of Journal of Cardiology looking at the junction of critical care, heart failure, interventional cardiology, a lot of what I do. And, thinking about all the different things that are necessary and required for these patients, whether that's PCR, hemodynamic support, revascularization, ablation, CRT, hemodynamic support to bridge to transplant, and then interventional heart failure therapies outside of that. And this recent paper, just published this year, asking that same question, transcatheter interventional heart failure therapies, looking at how this patient population perhaps class 3, maybe not quite end stage, or they're end stage and trying to bridge them to transplant or ventricular assist device. The role of novel transcatheter-based therapies for management heart failure, and if you put and where they focused was renal artery pressure optimizers, invasive hemodynamic monitoring like PA sensors, reverse ventricular remodeling devices like the core cinch, renal venous modifiers, and interatrial shunts like the V-Wave or alt-flow, etc. And here they give 2 examples. We actually have both. Dr. Mahadavan is doing the bioventrics, and I'm doing the core cinch with Levy Klein. And kind of combining all the papers and looking at by far not a comprehensive list, but some of the areas of investigation. You could see that, of course, there's percutaneous revascularization, this invasive hemodynamic monitoring like PA sensors, but there's renal artery pressure optimizers like the aortics, like the second heart assist, Rayton catheter pumps, venous flow control like precardia, LA decompression like the V-Wave or the alt flow, which is left atrial to coronary sinus shunting, LV reshaping, valve repair and or replacement, cardiac resynchronization therapy, cardiac modulation, cardiac contractility modulation, and autonomic intervention and GSN, greater saphenous nerve denervation for HFpEF, or baroreceptor stimulation, also something for a patient with HFpEF. Let's see how these therapies could help a patient that's really quite sick get out of the woods. This is a 60-year-old lady. First time I saw her was in clinic. She had come with her daughter, and she was clearly in cardiogenic shock in my clinic as a new patient visit. She had come with a history of she had been in Los Angeles where she was visiting another daughter, and there she was in cardiogenic shock and required a balloon pump, and was transferred to USC where they evaluated her for a VAD and transplant. She had an EF of 10%, and they found that she had severe PAD and she was too frail. She was very skinny. And so they discharged her on milrinone 0.375 and sent her back up to the Bay Area to come see me. And she had recent labs done before seeing me that her lactate was elevated. It was 3 days ago. And on exam, she was cold and clammy. BNP was 15,000. She was not tolerating any medications. She was hypotensive. She had worsening AKI. And she, of course, you could see the EKG was RV paced on 115. Her underlying was a left bundle. She had no CRT. And she had unrevascularized multivesical CAD. She had LAD disease, she had CIRC disease, she had RCA disease, all very significant. She's hypotensive tachycardic. This is her echo. You can see LVEF is about 10-15%. So she was admitted. She had a very long hospitalization. We started with a CRTD and viability, showing viability of the anterior wall, and either hibernating or scar of the inferior wall. The right heart cath early on was done, showing RA of 14, PA 60-30, wedge of 27, PVRs elevated. So combined pre and post cath BPH. The Cardiogenic was borderline, but we tried to wean her off milrinone to Entresto. She had worsening AKI, which peaked around 2.6. She was too frail, so and severe PAD. Many of my colleagues saw her, and we weren't able to move forward with her for transplant or VAD. Eventually, we got her creatinine improved to 1.95, but stuck on milrinone, went for left heart cath. You can see severe PDA disease here, PLV disease here, and then here you can see really what's the culprit issue is this subtotal long proximal to mid left LAD lesion and a very small underfilled LAD. This is really where the majority of that ischemia is with the cardiomyopathy. One of my mentor says the LAD is king. And then the CIRC here, small but clearly diffusely calcified and severely diseased. We fixed that, right? So I fixed the LAD, and the LAD pumped up really nicely. But we sent her out. She returned 3 weeks later and becomes heart failure. And we did a repeat wire cath and showed RA pressure 4 by 19, Cardiogenic 2.9 was preserved. So we decided to move forward with the CardioMEMS PA sensor. And with that, she had frequent outpatient follow-up and diuretic titration. You can see, if you're not familiar with the PA sensor, this is what we can see. Every time they upload this one shot of this once a day, we could see it daily. pretty much immediately. We were able to get her on Entresto, get that up to 49, 51, 97, 103. We got her on Farxiga. She could not tolerate beta blocker. Renal function stabilized, fixed the RCA stage fashion. She's doing well, alive, 1.5 years out. There are more therapies. There are very novel therapies that 3 years ago was still investigation, but now we're enrolling. So aortics is one of the many, perhaps one of the three main cardiorenal syndrome devices. So their first focus on a pilot study of 10 patients, obviously not randomized, is cardiorenal syndrome. So worsening renal function greater than 0.3 is by 48 hours diuretics. DView is the PI of this trial here. We implanted this back in December. It's RTR access. We leave the device above the renal artery. We know where it is based on bony landmarks. We have a CT scan prior. So we want to be above the renal arteries. And this is a pump that pulls blood from the descending aorta and increases the fusion pressures right here, which is where the renal arteries come off of. And this is left in the patient's body for upwards of 7 days. There's a small catheter that comes out of the leg. And we use this special perclose technique where we take the sheath out, but we perclose artery down into the smaller catheter. And then we sacrifice 3 percloses to leave a 4th. But they're able to therefore sit up and even stand with this device in the groin without any lower extremity ischemia because it's a small catheter. And you can see for this patient, I plotted out her creatinine, which she had first come in. Her issue for going to transplant was her PA pressures were too high, and her PVR was high. She was an HCM patient. And so we diuresed her. Initially, her creatinine improved, but with ongoing diuresis, creatinine started declining, peaked at 2. A device went in, and with the device in, even though she didn't necessarily pee more, her creatinine came all the way down to 1. What I was most impressed with is when the device came out, even with ongoing diuresis and ongoing weight loss and decreasing PA pressures, her creatinine stayed well below 1.4 until the time of transplant. This is where she got transplanted. There are other therapies we sometimes use off-label for this cohort to help them exit, have an exit strategy. 65-year-old lady, 5'8", blood type O, history of non-acute cardiomyopathy, yes, 10%, LV 7.6 centimeters, pulmonary hypertension, COPD, ILD, 50-year pack year smoking. She had CT with emphysema basilar fibrosis, amyloid deposits, not an OHT candidate, but kind of stuck on meronome, 0.375 current index is marginal. Her blood pressure was in the 70s. See, even with diuresis and normal RA pressure, she had very severe MR, large regression fraction, greater than 50%. These are patients who used to leave this alone because you worried that closing it that it was a pop-up valve and that the LV needed it. I think that's really been turned on its head. So patients who are of this phenotype, we looked at a cohort of 33 patients. 25% of them were on balloon pump and Impella. There were many of them on inotropes, and doing MitraClip on these patients, no implant failures, all patients extubated after the procedure, good anatomical results. You could see that the VIS score, so the inotrope use decreased, cardiac index improved, and for patients who had strong Gans catheter pre and post, you could see that improvement was pretty consistent, and renal pump function improved after post-op day 2. You can see for per patient, the large majority of patients had improvements in renal function. Post-repair, this patient actually did pretty well, traced residual MR, and was alive over a year out, and have since lost ability to look at her chart to see how she's doing since she got repatriated to Kaiser. Another patient, similar profile, 8.7 centimeter LV, EF 15 to 20%, already has a CRT but has severe functional MRTR, was admitted elsewhere and brought here for bad eval, but was declined due to a multitude of reasons. We tried to get him to another center like CPMC in Stanford. It was he was declined there. He was diuresed 40 plus pounds, but we were unable to wean the neuron off. And you could see potentially why a lot of his regression fraction was going backwards, blood pressure in the 70s. And this is a patient that we also fixed MR, 2 clips, LV didn't fail, and we actually got the V wave, the mean pressure from 27 down to 13, cardiac CVO2 by a pick. The 4 values before the procedures in the 40s and 50s, and after 70s to 80s. And no enough neuronal discharge 3 days later, alive, greater than a year and a half out. I'll try to skip ahead a little faster, but basically, there is a registry for these patients, MitraBridge. Essentially, looking at patients of this cohort, large dilated LVs, low cardiac indices. About 31 of these patients in this cohort were actually on a transplant list, and 5 of them came off after MitraClip procedure. But it's not the end of the story, right? So if you look at their 2-year data, I think that the device works because you stop, you halt, you pause, you slow down LV dilatation in the setting of mitral regurgitation. In patients in the control arm on ongoing maximally tolerated GMT, the LV continues to dilate. Patients without a clip device, that slowed down. EF really stayed the same. It's not an EF device. And the reality is LV dilatation or LV remodeling is really important for the therapies we use to work. This is an older meta-analysis pre-Entresto. I looked at 30 trials, RCTs, beta blocks, ascenders, Rs, spironolactone, CRTs, all improved LV size. And that LV size improvement, so mean change in EDB, if it got better, had a more favorable outcome in that study. If the improvement didn't change or got worse, then it had a less likely chance to be a favorable result. Things like evaporating, for example, did not improve the LV size. And so we have now embarked in trials. This is in the IDE. This is in the landmark trial now, RCT, and we're involved in using a cinch to promote LV remodeling. Their early data, non-randomized data, does show not just acute LV remodeling, but that LV remodeling seems to continue over 12 months. But of course, this is not randomized, and we really need randomized data to know whether or not this therapy will work. So I think it's just getting more complex in this area of heart failure and MR in the dilated heart, whether or not we would percutaneous mitral valve repair, whether or not it's too late, whether or not we should be thinking about LV remodeling or cardiorenal syndrome devices or LVAD and OHT, and it's getting very crowded, very exciting there. And finally, I leave you with another therapy for HFpEF that's also emerging. It's really exciting. Spinal nerve originates between T5 and T9 thoracic sympathetic ganglia. It's a source of excess blood volume that results in elevated blood pressure during exercise or times of stress, and that the sympathetic nervous system could be overactive and cause a vascular vasoconstrict. Now we could potentially ablate this process, improve venous compliance. There is surgical data. This just came out of 10 patients where they had greater spike nerve ablation via VATS, a minimally invasive approach. Reduction in wedge pressure you see in patients at 12 months, the black line versus the baseline has improved. Of course, not randomized, and function class improved as well. This is a patient we did with endovascular ablation, not surgical. The patient at baseline wedge pressure was 12. With leg raise, the wedge pressure went up 6 points. And then with even, I believe, 2 or 3 minutes of exercise, 2 or 3 minutes into the protocol, the wedge pressure had gone up to 31. And this is a patient that we were able to successfully denervate, and we're following very closely as part of the GSN denervation trial, Rebalance Heart Failure. I think it's really exciting. There's a lot of new therapies, and instead of talking about them coming in the future, they are now enrolling, and we are involved in a lot of them. The orange are the ones we're particularly involved in, and we'll see where these therapies go. Some, of course, will be successful in RCT, some will not. So when I think about what I do in interventional heart failure is really it's one continuum of the same heart failure patient. When I see the patients first, I always first maximize GDMT. But often they do need disease-modifying interventional therapies. You may offer that to class 2 patients, such as the MitraClip for FMR. But then, of course, for patients that have refractory symptoms, then you may want to offer some symptom-focused interventional therapies that may not be disease-modifying to help them improve their quality of life. And of course, this field is also very integral in patients that have acute Tom's heart failure, cardiorenal syndrome, or frank cardiogenic shock to help bridge them to heart transplantation or recovery. Thank you. Let's stop here.
Thanks, Dr. Cheng. That was really great. We have a couple more minutes, so I'll see if there are any questions. I had a quick question. One of the last cases you mentioned really touched upon, patients who are referred to us from other hospitals that don't necessarily have as robust interventional heart failure exposure. And so I was wondering if you could comment on, the efforts to communicate with more community-related hospitals and clinics and involve them in some of these trials, as well as inform them when they should be referring these patients for consideration for these interventions.
Yeah, I think it's always a little tricky. I think when our therapies become more established, then I think that outreach would be more in line with evidence, right? So, right now, a lot of these therapies are investigational. So I would probably say to referrings, well, send us your patients that really are looking for more than you're able to offer, right? So patients that are already on GDMT, the blood pressure is on the lower side, maybe they had a heart failure hospitalization, and they're just generally not doing well. They're in class 3 symptoms. And, we often see patients that are written off as class 2, but once you ask them, what are you actually doing? They're doing very little, and they're like, well, if I don't do the groceries, or if I don't do, this thing I like or that thing I like, then I don't have symptoms. But if I even try to walk 2 blocks, I get really short of breath. That's class 3, not class 2. So I think as these therapies become more not just symptom focused, but also disease modifying, and I think that's where we can spend a little more time with referrings to say this is the right thing for your patient. For now, I think it's really trying to capture patients that have refractory symptoms to their current pharmacological therapies. Obviously, for patients in shock, we like to get them earlier rather than later. But that's an ongoing struggle. We usually hear about them pretty late.
Okay, thank you. I know Dr. Redberg has a question. Dr. Redberg, I don't know if you'd like to ask your question in person.
Sure, be happy to. Thanks. So thanks for the talk and sharing the cases. I'm wondering if you would comment on the lack of randomized trial data that compares these various mechanical circulatory support devices to more conservative management. And then also after that, pairing it with the observational studies, including the one in JAMA that show a higher mortality for Impella compared to balloon pump, although I will note neither of those have been shown to be better than leaving these very sick patients on medical management alone.
Yeah, no, it's very, 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 two very good points. So the DURA study actually did show earlier on, and it talked about how Impellas were associated with higher vascular complications and bleeding and blood transfusions and mortality. I will note that obviously was non-randomized. It was a retrospective analysis of 2 ACC registries, combining a shock registry with an AMI registry. It was looking at AMI cardiogenic shock specifically, and they excluded all patients that had 2 devices. So patients that got a balloon pump first and then got Impella were excluded, whereas I would think that those patients should be in the balloon pump arm, since it's balloon pump failure, the intention to treat was a balloon pump. So, but clearly, and then we look at that cohort of patients too, a much higher prevalence of using Impellas in tertiary centers like ours, as compared to community centers, perhaps due to access, but also perhaps due to the acuities of patients. So I do think that to me, that paper shows you shouldn't use an Impella or even a balloon pump routinely, right, as compared to medical therapy. But I'm not so sure it tells me for sure that using Impella for a patient that has failed balloon pump is necessarily the wrong thing. I think there is one randomized trial, very, very small. I'm almost embarrassed to talk about it, right? The ARREST trial, looking at 30 patients that were randomized to ECMO or ongoing CPR, patients that had no return of spontaneous circulation after VT-VF rest with an average of 5 shocks. And when they got to the ER, none of them had return of spontaneous circulation. And so in that cohort of patients, at least, if you got randomized to ECMO arm, your survival at 6 months with favorable neurological outcomes was 43%, 6 patients out of 14. Whereas in the patients that got ongoing CPR and no ECMO, they were all dead at 6 months. So, I think the truth is somewhere in the middle, right? I think for sure there are patients that would do just fine if we left them alone instead of escalate to a balloon pump or Impella or ECMO. And, that study has not been done. But I think there are also patients that clearly are sliding, deteriorating in front of you, that medical therapy really is associated with poor outcomes. And that's been shown in multiple registries as well.
Sure, thanks. I mean, I agree. We can speculate on where the truth may lie, but I do think a randomized trial would be really helpful, and one will be done. I would just comment, like for CABG, if a failed PCI goes to bypass surgery, the mortality would go to the bypass, right? Not the PCI if the patient dies on the surgical table.
Yeah, well,
so you're proposing something different though for Impella and pump.
I am, because it's there's always been this idea whether or not you should reach for a more quote unquote aggressive device, so a device that may support the patient better, but have higher complication rates, versus device titration, where you start with a lesser device, so a smaller bore device that has less support, but maybe enough. And if it fails, move on to a larger bore device with higher complication rates. And so that's what I meant by looking at the patient that went from balloon pump, failed it, then went to Impella. Well, that's device titration. That's similar to patients where you start with a balloon pump, I think, than more similar to patients where you start with Impella. Yes.
Thank you. Okay, I'll let Dr. O'Brien ask the last question before we head off.
You had to be the last question. Oh man, the pressure. Richard, one of the thoughts I wanted to ask, obviously early intervention is always like the name of the game with almost everything. And, you guys have all reached out to me with some of the trial stuff, and and I was interested if you've had any thoughts on how we identify these patients early. And because obviously, very much like your hypertrophic cardiomyopathy example, you get pretty far down the rabbit hole, and then you're trying a device, and it wouldn't be shocking if a lot of failure was just due to late recognition. Have you had any thoughts of ways we could improve diagnostics, do comprehensive panels, early screening, and things in your experience?
Yeah, I mean, it's a great question, and I think that I guess for me, the way I think about it is that you have to have the solutions, right? It's like, you have to do every test you order, especially ones with risk, that you put your patients through. It has to change. It has to mean the test result has to mean something different for their therapy, right? It would modify the treatment option. And I think a lot of this is still emerging, and we're gonna get a lot of great randomized data on a lot of these novel heart failure devices. But we're not quite there yet, right? So, I think that patient with HCM that had high PA pressures, to say, well, had we gone to her earlier, we would have started with aortics earlier, or we would have started with, pulmonary denervation, or a shunt or whatnot. I think it's probably a little too early to say, because the data is not yet out there for the therapies. But yeah, I mean, I think when the therapies start coming out, I think a lot of us in this field feel like we're going to go back to hemodynamics, right? We really need to figure out the difference between somebody who increases in their left atrial pressures with exercise versus somebody who has elevated left atrial pressures at rest but don't increase it much, or one that increases left atrial pressures but increases their PVR even more. And we really we'll have to start going into the weeds about identifying different patient profiles and characteristics to kind of decide which device may or may not help them, because all these devices want a really broad patient population, as big of a indication as possible, right? And there's a lot of overlap. But I think we won't get there until we get some good RCT data showing that these devices will work, either for symptoms or to actually modify the disease.
Great. Thank you guys so much. Thanks for the participation. And thank you everyone for joining us. Next week, we'll have hopefully some people presenting their ACC presentations. So as a reminder, please let me know if you're presenting. And if you'd like to do a practice session, we can have that, we can coordinate that for next week. Otherwise, have a great rest of your week, guys.
Thank you.